Good morning, doctors. On behalf of Indian Dental Association, this is N.K. Prasad welcoming you all for today's webinar. To begin with, I would like to thank our sponsors, Synergy Specialist and RF America. Thanks a lot, Darius. Thanks a lot, Jesse, wherever you are. Today's topic, ceramic dental implants, its material evaluation and clinical application. A very brief introduction about our speaker, Dr. Mona Monzavi. She is a board-certified periodontist and implantologist, and she received her DDS degree from University of Pittsburgh and her certification in periodontics and implant surgery from Loma Linda University, Loma Linda, California. She also completed master's program and published on the topic of low temperature degradation of zirconia dental implants. She is a recipient of multiple awards for her publication from California Society of Periodontology, Western Society of Periodontology, European Society of Ceramic Implantology. She is a traveling periodontist and she places ceramic implants on a regular basis. She has conducted and published a long-term retrospective study on patients receiving zirconia dental implants. The presentation will go for a good hour to hour and 15 minutes. Then I would like to bring in our sponsors from Synergy Specialist and RF America as well. So later on, we're going to open up for question and answers. If you have any questions, please post it on our chat box. 2 units of continuing education will be provided. Enjoy the presentation. Doctor, all yours. Thank you.
Good morning. Thank you, Dr. Prasad, for the kind introduction, and thank you for the invitation. I am very excited to share some of my knowledge on ceramic dental implants. So, as you mentioned, I'm a traveling periodontist, and I have a lot of experience actually with ceramic implants, both in terms of placement and in terms of research. I've done some publications, which I will go over today. So this is my outline. I'm going to start out with the introduction, why I think ceramic dental implants should be considered in some situations. How did the material have changed over time? How has it evolved? The material properties, titanium versus zirconia, zirconia crystal structure, a phenomenon called the transformation toughening, the different manufacturing procedures of zirconia, including grain size, its purity, porosity, additives that are added, surface treatment, fracture resistance. low temperature degradation, and then I will finish up with biocompatibility studies, osseointegration studies, and then my own clinical cases. Um, so why do I think we should consider placing ceramic dental implants in some situations? I, by no means, I mean it should replace the titanium implants, but I think there are indications to place this type of implant. And definitely in cases where it's a steady case, anterior incisor case with lack of attached tissue or a thin gingival tissue, thin keratinized tissue with titanium implant. If we have a thin buccal bone, thin gingival tissue, we get the gray shimmering of the gingiva around the implant, which can be anesthetic, and it will require additional tissue grafting surgeries, connective tissue graft, or gingival augmentation. But for ceramic implant, because of its bright color, we actually don't see this problem much. Even in cases where there is recession or lack of attached or keratinized tissue, there is no gray shimmering or gray color. So it's a very aesthetic implant because of its bright color. This particular study evaluated the color changes in soft tissue using a spectrophotometric evaluation, and they simulated the thickness of the soft tissue using a tissue graft on porcine jaws, placed tissue graft of different thicknesses under a flap, and then they placed 4 different material under the flap. So they wanted to see whether there's going to be color changes based on different material and also different thickness of the tissue. So they had these 4 different material listed here: titanium, veneered, zirconia veneered, and then the color evaluation was done by a spectrophotometer. This bar chart shows the changes in the color, and this line shows the level from where the naked eye could see the color changes. So basically here they found that titanium soft tissue of up to 2 millimeter still showed grayness. So even that much thickness in this situation showed that there was some color changes. For zirconia, up to 1.5, still it was white. So they concluded that the color change depends on the material and the mucosal thickness. Another reason that I think these implants have an advantage is the improved soft tissue profile. So we get a very nice attached and keratinized tissue around the abutments and the implants. The tissue sometimes even moves coronally, so we have to really uncover the implants and remove tissue. But we get overall nice attached and keratinized gingiva. We don't know scientifically why this happens, but there are studies that have shown increased mucosal blood circulation around zirconia compared to titanium, and reduced inflammatory concentrate around zirconia compared to titanium. But we need more further investigation to know why we see this nice result. We also see clinically less bacterial plaque around zirconia. In vitro studies have been done. This is one where they use the pure Straumann ceramic implant and also a tissue level Straumann titanium implant. They had discs of the machine surface area and cultured bacteria over the disc. of the machine surface, which is before and after culturing the bacteria, and then the sandblasted and acid etched surface, also they cultured the bacteria. They compared these to the discs from titanium with bacteria cultured on the machine surface and on the sandblasted acid etched surface. This study found significantly less biofilm mass and thickness on polished and rough surfaces of zirconia compared to titanium. So it indicates that we may have less chances of developing peri-implant mucositis and peri-implantitis, which means that in cases of patients that have history of periodontitis, maybe this would be a better option. This is another study where they use the similar types of implants, Straumann Pure and the tissue level. Here they evaluated the peri-implant bone loss. So it was a ligature-induced peri-implant bone loss evaluation that was done through radiographic evaluation. 20 implants in each group was alternately placed in mandibles of 5 canine dogs. And this is the timeline. So at 4 weeks of functional loading, they started to place, to stop the oral hygiene procedures and initiated the bone loss by placing the cotton ligatures between the pockets. Then the ligatures were removed, and that was the active progression period. At 8 weeks, it was removed, and they allowed the plaque to accumulate for 16 more weeks. That was a spontaneous progression period. And then they used a standardized radiograph to evaluate the bone loss. So this is at the beginning where they placed the cotton ligatures. These are the titanium implants, and these are the zirconia implants. Here the ligatures were removed. So we can see the bone loss, pretty extensive on this sample, and they actually lost 1 titanium group. This is 2 weeks after ligature removal, and then 16 weeks after ligature removal. So they had bone loss of titanium implants and no zirconia implant failure, radiographically less crestal peri-implant bone loss around zirconia compared to titanium, which was significant. And this is a chart where you can see that overall there was less bone loss in zirconia compared to titanium. And the significant was in the beginning of the active progression to end of active progression, and also beginning of active to end of a spontaneous progression. So this is another study that points to possibility of less chances of peri-implantitis around these implants, and maybe an option for patients with history of periodontitis. And then the most important, also one of the most important reasons is also patient desire. So there are a group of holistic patients that do not want any type of implant other than ceramic, or they don't want any metal inside of their mouth. So this option will accommodate their preferences for metal-free treatment. We can give them an option and give them this treatment option if we know about ceramic implant and place it. Also, patients that are concerned about metal sensitization or allergy, this is a great option for them. A little bit about metal allergy. So allergy either occurs to type 1 or type 4 through the specific immune system, but with metal allergy, it's type 4, and it really happens only to the alloy particles of the titanium implant, but not to titanium itself. So usually the alloy of titanium implant contains nickel, cobalt, chromium. So it's mostly, if it happens, mostly it's to nickel. And how it happens is nickel ions activate, they form haptens, or essentially they form these antigens. The antigens are presented by antigen presenting cells to T cells, which get activated, proliferated, and they start the cycle of inflammation through activation of cytokines, interferons, and interleukins. What about titanium? Can we have a titanium allergy? So with titanium, we actually do not form ions, free ions. So titanium becomes oxidized when it gets exposed to the environment. It forms into titanium dioxide, which if there is any reaction to titanium dioxide particle, it's going to be a non-specific immune reaction through foreign body reaction. Because we do not form the ions, we only have titanium particles. So this process of specific immunity type 4 does not apply to titanium. And we cannot really have a titanium allergy. It's more like a foreign body reaction. And how that happens is we have the titanium dioxide particles that activate the macrophages, and which activates the cytokines, and leads to foreign body reaction only to metal particles, no metal ions. There was a study that showed we get highest response of TNF alpha secretion actually to titanium in tissue, but to other oxide ceramics such as alumina and also zirconia, almost no TNF alpha secretion. So foreign body reaction does occur to titanium inside the tissue, which leads to the next study where this publication was published in Journal of Periodontology. They evaluated the levels of submucosal plaque, titanium particles, using inductively coupled plasma. So they took submucosal plaque of healthy implants and also peri-implantitis cases of titanium. This is showing the plaque level in the peri-implantitis versus the healthy group. And they measured the amount of titanium particles inside the plaque using a special instrument called ICP. What they found was there was significantly higher mean values of titanium in submucosal plaque of peri-implantitis compared to healthy groups. So this points to a possible association between titanium dissolution, foreign body reaction, and peri-implantitis, but it's something that needs to be further investigated to know if it is the titanium particles that can lead to further or increased inflammation in peri-implantitis, or it's just the release of titanium because of increased inflammation. So that's a big question that we really don't know the answer at this point. So in conclusion, I think that these are some of the reasons in aesthetic cases, soft tissue is really good, and we don't need additional surgical procedures. Also reduce biofilm, reduce bone loss, or maybe in patients with a history of periodontitis, severe periodontitis, this could be an option. And also for patients that are holistic, we can provide this option. So now I want to go over the history of ceramic dental implants. The very first material that was introduced, it was in 1960 by Dr. Sami Sandhus from Switzerland. The material was actually made out of aluminum oxide. So it was not the zirconia that's used today in ceramics. The implant was called the crystalline bone screw. It had high biocompatibility, so good osseointegration, good bone to implant contact, and also soft tissue integration. But the mechanical property was not great. It was had high hardness, high modulus of elasticity, so it was brittle and stiff, and also no bending strength. So the fracture toughness of it was not high. Then the second design of the same type of implants was introduced for immediate implantation about 5 years later in Germany by Dr. Scholl. And these were the tapered design made out of aluminum oxide for immediate implantation. So these were the first two ceramic implants that were first introduced. They, like I said, they were made out of aluminum oxide, high biocompatibility, but poor mechanical properties. They fractured a lot, and also they were only one piece design, so the prosthetic flexibility was not much. The smooth surface also led to a longer healing period. So these implants were withdrawn from the market because of the complications. So the current material that's used today for ceramic implants is zirconia, made out of zirconium dioxide. There are many companies that now produce these types of implants. Also, some of the larger companies like Straumann and Nobel provide the implants. The two major material that's used is the vitria, stable zirconia polycrystal, and the other group is the same with the addition of more aluminum. But before I get into a little bit of detail of zirconia, I want to distinguish the difference between titanium and zirconium in terms of material properties. So we know titanium is a metal and zirconium is also a metal. Titanium gets, when it gets exposed to the environment, the surface forms, it becomes oxide. So it becomes titanium oxide when it's exposed only on the surface, but not within the core of the material. For zirconia, actually, when it gets combined with oxygen, it's the entire material gets combined. So every little grain then is made out of zirconium plus oxygen. That's why zirconia is considered to be a ceramic, because the whole material is oxidized and inert. But for titanium, we still have free ions inside. So it is still a metal. So this is a distinction, and it has created a lot of confusion in terms of the fact that many say that zirconia is still a metal, but it's the zirconium dioxide that's a ceramic. Okay, so what about that atomic structure? So titanium has, as I said, it has the free ions inside the core. The bonds are weaker, elastic and plastic formable bonds, and there are all these free electrons. So that's important to know because of that, we get high electrical and thermal conductivity and reduced electrical and thermal isolation with titanium. Zirconia is different because we get these strong covalent bonds between the zirconium dioxide grains. So there is no electron inside. We have no conductivity, no electrical or thermal conductivity, and we have increased isolation, increased electrical and thermal isolation. That's very important to understand because we need to understand that so that when we place these implants, we don't overheat the bone because zirconia is not a conductor of the heat. So during placement, if we place them we place too much torque at it, we can produce a higher temperature than the normal, above the threshold that's recommended, which is 47 degrees Celsius. We know above that we get bone necrosis. So this heat is not going to be absorbed by the implant. It will be sent out to the oral environment inside the bone, and we end up overheating the bone. So to prevent overheating the bone, we have to really prepare the osteotomy well. So we have to use the profile drill, and we have to use the thread cutter, and we should also never torque it more than 35 Newton centimeter. Try not to torque it more than that because we cause more heat, and that will lead to bone loss around the implant and even maybe bone implant failure. So it is a very technique sensitive placement to place the zirconia implant because we do need to get a good primary stability, especially for the one-piece implants where we have the abutment exposed. But also, we don't want to put too much torque, which can cause to overheating the bone. So it takes a lot of care when we place these implants compared to titanium implants. So not all zirconia are actually the same. There are differences in the way they are produced. I already sort of covered the material composition. Manufacturing procedure really affects the density, the grain size, the surface treatment. Also, designs are different. We have the one piece, which the abutment is attached. And then we have the two-piece. We have bone level now available, tissue level, which most of the zirconia implants are tissue level. We have a screw retain, which Nobel and Ceramics have that. This system and Straman also have a screw retain. And we have different screw material for the screw retain implants. But one thing that we should understand with zirconia implants is the material. And I try not to go too much into detail of the material, but I want to cover the importance of it because it really affects the way we choose the implants for surgical treatments and how we place it. So zirconia changes its crystal structure. At room temperature, it's at its largest phase called the monoclinic, and at different temperatures, the crystal phase changes. So at above 1170 degrees Celsius, it changes to the smallest grain crystal structure, and above 2000, it changes to the largest. So different temperatures, different crystal phases with different sizes. That is important to understand because when these implants are heated at high sintering temperatures, they transform from large to small, and then when they cool down to room temperature, there's going to be that change of the crystal phase. So it goes from T to N, from small to large, and then we get this increase in size, increase in volume, and compressive stress along the grains, which can lead to fracture of the material when it cools down from high sintering temperatures. That's why to fix this issue, they have added oxide to this material. So the current material is not just zirconia, a little bit of yttria is added so that the grains are stabilized at the small face. And we will not have issues with change of grains and crystal faces at different temperatures. Also, the other group of material is zirconia white ECP with a large amount of aluminum, and those are the Xeromex and the C system. Almost all the other manufacturers use the white ECP with just yttria added to zirconia. So stabilizing the grains at the tetragonal phase has another advantage, and that is if you think of the cross-sectional cut of the material, and these are all the zirconia grains, and there is a mechanical stress, micro crack formation, those grains on the surface actually close the crack, and this is very interesting because the grains change in response to the micro crack. So they change from the small to the large on the surface, and that creates this increase in size and volume of the grains, increase in compressive stress, and then shields and close the microcrack. That's why these materials are actually very tough and they don't fracture easily because of these transformation toughening mechanism that really prevents these material, the bio-TCP material, from fracturing. So these are tough materials, but one thing that's important to note with regards to this mechanical property is that we should try not to grind the implants as much as we can, because when we grind the implants, we induce these transformations on the grains. We induce microcrack formation and transformation, and that may destabilize the material. So the best is always to choose the right abutment size. Each company has different abutment sizes, the short and the long. So treatment plan the case before. Make sure you have the right abutment size so we don't have to touch the implant surfaces and touch the abutment surfaces. So try not to grind. The last property of this material is that when there is moisture around, that TM transformation can form again. So the grains also, they transform in presence of microcracks and also in presence of water or moisture. And that also leads to this transformation, increasing grain sizes, surface uplift, and maybe lead to delamination of these surface grains. But we don't really need to be concerned about this because it was thought to occur at very high temperatures, 65 to 300 degrees Celsius. Although there were some issues in orthopedic ceramic implants, so that brought a concern in dental implantology, and that's why I actually went into doing my master's in Loma Linda on this topic since I was interested on this material. So I want to cover a little bit of my own publication on this topic. So what we did at the material department in France, this was a material scientist group that specialized on this topic of low temperature degradation or aging of ceramic implants. So we took the implants from manufacturing companies. We had Z Systems, we had Straumann, Z-Bone, Tav Dental, and Xeromex. They're all available commercially, so we can use these implants. Tab Dental provided also two other types of implants that had different grain sizes that were prototype. So one group was commercially available and the other two were not. And what we did was we used a technique where we artificially aged these implants, and that technique, it was an in vitro type of technique that predicts to about 60 years in human body. So we use this technique to age these implants, and that would correspond to about 60 years in human body, a long time. And we wanted to know whether it really, this aging, does it affect the dental implants? Should we be concerned about it, or it's not, it doesn't relate to dental implants? These are the cross-sectional cuts of the different materials. So it just shows how different each implant system is, even though they are the same material. We had the grain sizes of the zirconia was different for each group. For example, as Strawman had much smaller grain size, and then with Tab Dental, we had some of the largest grain sizes. Xeromex had these alumina grain. So these are all zirconia implants, but different properties because of the way they are manufactured. So what we did in this study was we first took an image of the thread of the implant. We took the thread of the implant. We used the gallium ion cut, made a small cut, and then we microscopically evaluated to see that cut, to see what has happened to the grains following aging them. So in this particular group, which was this system, there was some transformation to begin with because of the surface treatment, the laser surface treatment. And then after aging, there was some increased transformation, but very minimal, to about 2 to 3 more micron. So it was not significant. It was, even though it simulated to about 60 years in human body, it was very minimal. This is another sample. I'm not going to go over every single one. You can read the study if you're interested, but it's a lot of material content in there. And this is the Xeromex group. Before and after, you can see the alumina grains and some increase in transformation and microgrinding, but overall very shallow. These are microscopic images of one other sample, and here this type of image sort of showed us the different color of the transformed zone. So at low magnification, you can see that transformed zone was so thin that it may not really affect anything clinically. This is at high magnification. This is the thread. It was a little bit thicker along the valleys, but overall very thin. So with the first part, we concluded that overall there was not much transformation and microcracking. They all had some transformation, but it wasn't really significant. But what was important was the extent was affected by the grain size and other parameters of manufacturing procedures. So initial powder, surface treatment, and but overall, we thought all the implants are safe to be used clinically. What about mechanical properties? Did it affect the mechanical properties of this implant? This was part 2 of my project, where we took the same implant types, so Z-Systems, Straumann, Z-Bone, and Tab Dental. These implants were mounted at a 30-degree angle with a 11mm lever arm, and force was applied, a load was applied to these implants until it fractured. We did this before we aged these implants artificially and after. And then we calculated the bending moment before and after for each group. This is the Stroman, Z-bone, and TAP group. The fracture load is shown here, how much Newton load was applied until the implant fractured. So to give you a little bit of background, during chewing, we use about 45 to 150 Newton. And you can see all these fracture loads are way above the chewing force. Even the group that had the lowest fracture load, still it was way above the chewing force. During swallowing, it's 25 Newton, but during bruxism and parafunction, we have up from 500 to 880 Newton force. So that was a little bit, now when we look at our samples, for example, Stroman was still above this range. Z system was also very close to above this range. This group was below. Also, this group was very close, but a little bit less. So what's important here is that manufacturing procedures are important. So you see these are all different zirconia implants, but our results, though they're all pretty high, but are different between implant systems. So when we have patients that are bruxers, I would be careful and I would look at these numbers and make sure to have them have an occlusal, the night guard, or maybe in some cases they would not be a good candidate if we are using some implants that the fracture load is a bit lower. So this is something important to remember. So our conclusion was overall, one factor, the grain size, affected the bending moment, and the porosity also was a big one that affected the reduced bending moment in one of the groups. But overall, there was a high fracture load and high bending moment for every single group, way above the chewing force. So these were considered to be safe to be used clinically. So this is now I'm going to talk about the differences in manufacturing procedures. I think this is very, very important to understand because it changes the material properties. The way these implants are manufactured, it can affect the grain size. And if we have a too large grain size, we get too much transformation. So we may get microcracking. Also, they affect the implants by different surface treatments. So all these implants have different surface treatment. If there is too much roughening, too much surface treatment, that may also affect the material's property. And most importantly, porosity is very important to avoid porosities inside the material because that can lead to reduced fracture toughness of the material. So what are the different manufacturing procedures? One of the one is the ceramic injection molding. It starts with injection molding of the material, then shaping, and then there is refinement, sintering, hot isostatic post-compaction. The second technique is with green machining. So shaping of the material by milling and then sintering, and high isostatic post-compaction. So these early techniques do have some disadvantages because there is a binder involved with the initial material. When the binder evaporates, we can end up with porosities. And these porosities can reduce the mechanical properties of the material. So we want to avoid this issue by reducing the chances of getting porosities in the material. Uh, the advantage of this technique is it's cost effective, so it's cheaper. A lot of implants can be produced by this technique, but not necessarily the safest way. The best technique to use is the heat or hot isostatic pressing or hot hard machining. With this technique, the grains are pressed together to ensure there is no porosity within the material. So the mechanical properties is very high with this group because we get a very dense material. So this is a sample from one of the groups that I tested during my studies in France, and this is a strawman group. You can see that it's very well compact with no porosities inside. The disadvantage of this technique is it's complex and expensive. So it is not very cost effective, but it does provide the best material. So next, I'm going to now move on to biocompatibility studies, specifically osseointegration, which is very important. This particular study was done in mini pigs. They placed 48 acid-aged titanium. The bottom slides are titanium and zirconia in tibia of mini pigs. Histometric analysis was done at 1, 4, and 12 weeks. They showed bone to implant contact of 35 versus 47% at 1 week, 45 versus 58%, and 71 versus 83%. So there was no significant difference between osseointegration between zirconia and titanium implants, according to this study. The next one, it was done in 6 monkeys, 12 sample acid and acid-aged titanium, 12 sample acid and acid-aged white zirconia implants. Here they also evaluated the soft tissue cuff, the area of the connective tissue and the junctional epithelium. So what they found was the peri-implant tissue cuff was very similar between titanium and zirconia, 4.5 to 5 millimeter, and the bone to implant contact was 72 versus 67. Also no significant difference between groups. So they concluded the zirconia osseointegrates to the same extent. This last study on osseointegration, I included this because they had really nice histological sections. They had 14 one-piece zirconia and 7 titanium they placed it in the mandible of mini pigs. The titaniums were all submerged. Zirconia was either submerged or non-submerged. Healing of 4 weeks. Bone to implant contact was evaluated. Also, relative peri-implant bone volume density, which is the yellow along the threads, that was also measured. So this first slide shows the non-submerged zirconia group. These implants were exposed, and one of the important findings was there was remodeling of the bone, the connective tissue attachment, the area here, showed dense fibers that were parallel to the surface of the implant and down to the periosteum. So not perpendicular, but parallel, similar to what we see around titanium. Because they were non-submerged, they also noticed some downgrowth of the epithelium. Submerged group, here they had not much remodeling of the bone, also dense connective tissue attachment parallel to the surface of the implant. This is the bone to implant contact around the non-submerged group, and this is the submerged titanium group. And lastly, the submerged versus non-submerged zirconia. So the result was both submerged zirconia and titanium implant had bone to implant contact of about 53%. Here, as I mentioned, crestal epithelial downgrowth in the non-submerged, which reduced the BIC slightly. Relative bone volume density was actually higher around zirconia compared to titanium, but no significant difference. And the study concluded that they both osseointegrate comparably. Okay, so now I'm gonna go over some of my clinical cases and my experience, clinical experience with these types of implants. Actually, sorry, clinical studies, and then I'll go with my clinical cases. So this clinical study, actually, we did this in Beverly Hills practice. It was a retrospective evaluation of 1 to 5 years. And there were 24 implants, 12 patients. Here we evaluated the radiographic crestal bone level using ImageJ software. We had a high success rate of 92%. The mean peri-implant bone loss was only about 0.3 millimeter in only 33.3% of the implants. So about 70% were not much affected by bone loss. Gingival and plaque indices were low. And we concluded that we had good results, but this study is a retrospective, and because of the low sample size and the low number of implants, it's a huge limitation of this study. But with the limitations, it provided excellent aesthetics and clinical results. This systematic review contained 9 clinical studies, 326 patients, 398 implants, follow-up of 1 to 5 years. Their 1-year implant survival rate was 95.6% and a decrease of 0.05 per year after that. 1-year marginal bone loss average was 0.79. So there are some more clinical studies, but it is very limited. We need randomized controlled clinical trials for zirconia implants. That's what we are missing. And it's really hard to clinically show whether it is comparable to titanium. So that's a limitation at this point. But this is the current evidence right now with clinical studies. Okay, so some clinical cases. This was one of my earliest case that I placed the zirconia implant. I plan to do a D-system one-piece. These are tissue level one-piece implants. The advantage is there's no micro gap, and also it's tissue level. Disadvantage is that prosthetically, you have to make sure you get the perfect angulation for these implants because there is no margin of error. So it was placed And then I was, very excited about the soft tissue. This is something you usually see with zirconia. The tissue grows coronally, and it's very well attached. Sometimes you even get excess tissue around zirconia. So the result was good. That was about 2 years post-op, I believe. Case 2, this implant was uh, had a mobility, the titanium implant, so it was failing, and there was condensing osteitis. It was removed. I replaced it with zirconia implant, and in this case, we can see there is almost no attached or keratinized tissue. It's in the posterior mandible area. And this is following restoration, so no recession, 2-year post-op, even in presence of no tissue, no keratinized tissue, we get a very nice attached, healthy gingiva around these implants. So this is very special about zirconia implants. Case 3, this was also failing untreated tooth holistic patient. It was extracted. I placed the implant with PRF. I used PRF for almost all the cases. It prevents infection and improves the regeneration. So I use it for almost all the cases. This case also, you can see the soft tissue is very well attached, pink, healthy, and we actually had to remove it to be able to expose the implants. This is 2 weeks following the final restoration. This was the immediate case. Number 8 was removed. This case, I placed a 2-piece implant. Patient wanted to have a provisional restoration. So about 1 week after, we placed the provisional on these and reduced the occlusion. One thing with these implants, if we use a 1-piece implant, we should definitely use a protective stent because we cannot have any sort of trauma for this implant. If we do an immediate provisionalization, we have to make sure that it is out of occlusion and there is no there's occlusal clearance for it. For this case, it was another immediate implant case. So here 8 and 9 were removed. We plan to do 1 piece. It would have been nice implant. The 1-piece implants, you really have to pay attention when you go past the apex of the extraction socket. Because it's 1 piece, you may be a little bit too deep. So here we had to do a slight gingivectomy to expose the abutments. And then we placed the provisional crowns, reduced it out of the occlusion. And later, the case was restored by the general dentist. This is another extraction immediate implant case, number 5. The patient had abscess on the facial. So it was planned to be extracted with immediate implant placement. I don't recommend doing it with immediate 1 piece, especially. Even though I did this case, it's a little bit risky when it's a 1-piece implant. 2-piece would be better. But 1 piece, because this portion is exposed, and if we get any sort of trauma during healing, we may get a failure of these implants. So I think immediate implants with Zirconia best is most cases to do a two-piece implant. But we didn't have any complications with this case. And interestingly, even though there was a buccal bone loss, I only used PRF. Patient didn't want to have any sort of bone grafting material. But you see that soft tissue, this is at 2 weeks post-op, is at the level of the margin of the abutment. And this is 6 months after the final restoration. Nice attached soft tissue, small black triangles here. This is at 2 years. Nice attached tissue. We did not see any recession, even though there was a buccal bone resorption, no well-attached tissue. So overall, I was very happy with this case. This is another immediate implant case. Number 9 was removed, and the implant was placed with PRF. Then we gave the patient a protective stent, and during the healing time for about 4 months, and then the case was restored. So one thing with the one-piece implants, it's very important to use the CT scan, to use guides, and make sure that prosthetically we put these implants in the right spots. Because the one-piece nature, we cannot have any angulation errors. We can't prep the implants, we can, but it's not recommended. So best is to really plan the case beforehand, look at the CT, make a guide, make sure that we prosthetically place it in the right place so that it's restorable. This was number 18 and 19 here. So implants were placed. Again, one-piece implants. And you have to make sure you have the clearance occlusally and give these patients protective stents to wear during the healing time so that there is no trauma on this patient, on these implants. The challenge with these implants is the post-op. Patients forget to wear their stent, they eat on that area, so there can be more failure with the one-piece implant. If you think that patients will not comply, I would go with the two-piece. So this is my conclusion. Overall, I think that the modern ceramic material with the new manufacturing procedures have high survival rate and can withstand high fracture loads. The available studies are mostly in vitro and in vivo. They show equivalent osseointegrative capacity to titanium, reduced bacterial adhesion, reduced bone loss. There is minimal effect of low temperature degradation and improved mechanical properties. What is missing is the long-term randomized controlled clinical trials, which is needed to confirm the available data and recommend the use of these implants for everyday use. But there is enough evidence to use it in certain indications that I mentioned, like the patients that require the implants or they're concerned with the middle holistic patients, patients with history of periodontitis. So I think definitely we should have this as an option for our patients. So with that, thank you, and I'll take any questions.
Thank you very much, Dr. Monzavi. That was an excellent presentation. Yeah, it was a lot of information. Yes, we
Thank
do
you.
have some questions, and it was a great presentation, let me tell you. And
Thank
let
you.
me bring in our uh, Darius. Are you there? Darius looks like he's not there. Okay. I would like to request Dr. Shaikh et al. From RF America if you have few words for us.
Well, thank you, Dr. Prasad. Thanks for the opportunity. And Dr. Monzavi, that was a great lecture. You know, there was a lot of information, so I have to admit that I don't know a whole lot of what you talked about. So I guess the learning starts today. You know. So yes, Dr. Prasad, shall I just go ahead and go with my little presentation that I have?
Certainly, go ahead.
All right, great. All right, folks, I hope everybody can see the presentation. First of all, thank you for taking this opportunity and coming here to listen to some lectures on a Sunday morning. Like the old English adage, no good deed should go unpunished, right? So you had a great lecture from Dr. Monzavi. I'm pretty sure this is not going to be as interesting as that one, but I'll try to make it as interesting as it can be. Unfortunately, science often tends to be a little bit boring. So what do I talk about when I say UV active implants? So it basically means active implants. Active implants have been in the market through various manufacturers. Probably all the big houses do have active implants, and you must have heard about it, heard a lot of good things about it. One big barrier with active implants being adopted into clinical practice is the cost of the implant by itself. The cost seems to be a little bit oppressive, and at that time, most people shy away because at the end of the day, it has to make sense. The question is, when does it make sense to go towards active implants? And the pure fact for it is nothing but the science. So an active implant may not be a standard of care, may not be one that every patient would need, but there might be some properties in there that makes it important for some patients or makes it more effective on some patients. Um, so let's take a quick look as to typically what does active implants mean, and what do they do. So it's a fair. I put together a fair comparison between an active and an inactive surface. I'm not going to go through the entire science of it because it's a lot more than 10 minutes that I have over here. The basic idea is you have a surface that increases some property, which increases the vascularity and hence the osseointegration. So that's basically how you want to look at it. Now, what makes the active implants more effective is that it actually, for lack of better words, I've used something that's called as a wettability. So when the surface of an implant has more properties to attract more water, in this case blood, obviously blood's good, so it increases the bone formation, increases osseointegration. So that's the goal. Why UV active? So it's just that the ultraviolet radiation is very easy to achieve, so in many different wavelengths. It can activate certain surfaces. I mean, we use this on a daily basis in terms of disinfection, in terms of when you turn on uh, even a microwave, there's always a little bit of a radiation right there. So it has some good properties. So if you take the UV properties and then use those UV properties to activate the surface of an implant, you possibly could be getting now better results. So what do I mean by that? What are better results? What are the immediate things that we look at? So you can see a comparison image over here. So what does it show? What it shows is two different implants, and you can see how one is pretty much dipped in sort of like it looks like the color of the blood and it seems to be coated with blood, whereas another one that seems to have kind of like a thick, gooey I would say blood film around it, and it in turn it looks like it's hanging on to or sticking it to it something much more effectively. What that effectively means is that in terms of physiology, it is able to attract and retain a little bit of extra blood than a normal implant can do, and that's a property that makes it very attractive, because that's a good case scenario. It's used in various different systemic conditions. You can just use it even for increased osseointegration. I know somebody out in Southern California who actually uses it for cancer patients. Happens to have a practice that's located in a healthcare center, which has a cancer center, and he says that it's pretty effective by doing that. Now, when you go to what's the basic difference between a regular implant and a UV active implant? So we're looking at the hydrophobic versus the hydrophilic properties. So typically all implants are supposed to have some sort of hydrophilic property, but then what generally happens is these things are minimal, and there's not a whole lot of extra properties that can actually get defined. The active properties increase with the UV radiation that you actually see, that's demonstrated on the screen for you, and you can clearly see the difference between an active implant and an inactive one. I mean, when I say inactive, I just mean in contrary to the idea of activated implants. So what does it do? Like I said, everything has to have a reason. The scientific reason for this is basically we have to look at osseointegration as a property, and this is very critical. So if you look at these diagrams right over here, you can see the difference between the general implant and the UV active implant, the formation of the new bone. That is critical to the UV active implants, and that's critical to the patient, and it makes a whole lot of difference. So I'm going to keep it right over there, but what I do want to show you is a short video how the activation process works. But at the same time, keep in mind, there's some music in here. Please ignore the music. Unfortunately, some of these marketing gimmicks always tend to make it a little bit cheesy. I apologize for that. So, folks, that's what I wanted to talk about, today, and wanted to let you guys know about a few things that that you should probably look into. Unfortunately, I do not have any information on the UV active properties of any ceramic implants or if such surfaces exist. Dr. Monzavi is the best authority for those kind of things. So, with that, Dr. Prasad, you can take it away from me.
Thank you very much, Dr. Katal. Before I proceed, thank you, doctors, for your lovely wishes. Yes, thank you. And I'm grateful to all of you for your lovely wishes. Moving on, Darius, are you there still? Minal, is Darius available?
No, he hasn't joined this morning.
Okay, if that is the case, I will continue. Dr. Monzavi, would you talk about this UV treatment if you are doing in your practice, what Dr. Katal was mentioning?
The UV activation is basically a technique to improve the hydrophilicity of the implants. So that will induce better osseointegration. I haven't been using much of it, but I'm a little bit familiar on the technique. But basically, the idea is to increase the hydrophilicity of the implant surface for better integration with the bone, because the blood, just like Dr. Kotal mentioned, it will attach the implant surface much better. So we get more osseointegration.
Thank you. Similar note, Dr. Katal, would you talk on that? What is the procedure? How does it work?
So it's an interesting question. What's presently okay, let me just clarify this terminology. First it's the active implant as such, what Dr. Munzabi just explained, right? And I think she gave a very good idea of what active implant would do. You can buy an active implant which actually is pre-activated, which what that means is it is a premium product, so it's definitely much more expensive than actually going into buying a regular implant by itself. So when you buy these active implants with pre-activated properties, you shelf it. And when you shelf it, one of the biggest problems with shelving anything is that it has a shelf life. And there's a shelf life degradation that happens over a period of time. So within about like 3 to 6 months, and people don't consume implant one at a time, right? So general pattern is, okay, someone's going to go buy 50 of them or 100 of them and shelf it. So what happens is, now you're not going to use your 100th implant on the first day. You might use it on the, let's say, on the 100th day, which means it's over 90 days. So in that period, there's a natural degradation of the active properties of the surface. In terms of UV active implants, what that means is that you're using UV radiation to do a chair-side activation. So the video that I showed to you is a chair-side activator. It's the size of a blender. So basically, you have this prepackaged and implants. Believe it or not, it's not the active implant that makes it really expensive. It is actually the packaging of it is very expensive too. In fact, since I understand the cost of this better than probably everybody else here, the cost of packaging a UV active implant to preserve its active properties is almost equal to the cost of the implant. So it definitely falls in a segment which is premium. So you take that implant, you're able to now place that into the UV activator, chairside activator. You're able to activate the surface in about like 20 seconds, and then you take it out immediately and place it on the place it in the patient. So that's the biggest difference between a regular active implant and a UV active implant. Dr. Prasad, did I explain that well enough?
Absolutely, absolutely. And that was a good explanation, something we got to know. Darius, are you there still? Or are you going to take
Yes,
up?
I'm here.
Okay, please go ahead, Darius. It's your turn now.
Oh, hi. Hi, everybody.
Hi, hi.
Hi.
A little about Synergy Specialist. We're the middleman that comes in and helps set up the whole perio-GP relationship. We work on behalf of the periodontist, so it's in our best interest to put together like a long-term sustainable relationship together. The things that we can do to help out to lift the heavy load off of your front office manager's plate is by teaching them how to do the billing, facilitating the credentialing, putting together a perio referral protocol together as a team, and just developing a relationship long term where the perio can come in at least once a month and handle not just like perio treatment, soft tissue, but also like implant cases, bone graft cases. Typically, the periodontist brings in their surgical instruments, the motor, the implant system. Um, Restorative is up to the owner dentist, the GP, and we work off of a 50-50 split off the adjusted production together. Some perios are looking for like a daily minimum, not too high, around like 1,500 a day after like, let's say the third month or so. But for the most part, they're just looking for at least like, 6 to 8 consults plus figure, that could generate easily like $10,000 in production per day.
Thank you, Darius. Again, doctors, if you have any questions, please post it on our chat box and we'll be glad to answer the question. Continuing, Dr. Monzavi, zirconia dental implants, where are we now and where are we heading?
Uh, that's a very good question. I think that we are at a stage where we know that these implants are predictable to use, and there are indications to use them. Like I mentioned, in aesthetic cases, cases of history of periodontitis, we can use these implants, anterior cases, and cases with patients that are holistic, so they only want something that's not middle. So this is a great option to learn about and also provide as a treatment for those types of patients. We are still limited for full mouth cases, and that is just because we are limited due to the development. Still, the manufacturers are still developing the implant designs that would go for full mouth cases where we can use different abutments with angulations even more than 15 degree. But prosthetically, we are limited really to do full mouth cases. So it is, we can do it, it's just prosthetically we are limited with the material that's available right now. So I think, but for single cases or even multiple implant cases, we have the option. We have different companies now. Straumann has this as an implant option. They have a 2-piece. They have a 1-piece. They have a screw retained 2-piece implant available. Z System, that's one of the oldest manufacturers that I also use. And they have many different options now. They have a bone level implant as well. There is Nobel with a screw retained abutment, Xeronix as well with a screw retained abutment. So the only thing is that we need to really learn the surgical technique of placing these types of implants because it's different than titanium. The technique to place zirconia is completely different than titanium because the material is different. So if we use the wrong surgical technique, then we can have issues. That's why I would always, review the techniques, take some courses on it, make sure that I'm confident, or specialists that are placing or have experience with placing these implants, they can provide this sort of treatment option. But it is definitely something that we can use. It has great advantages, and it offers a great amount of advantages to our certain group of our patients, I think.
Thank you, Doctor. When you mentioned the technique is different, I'm talking titanium versus zirconia. Would you briefly go through the technique? What exactly do you do when you place zirconia implant?
So with zirconia implants, it's tricky because we want to get a good primary stability. And with a good primary stability, that means the torque should be around 35 Newton centimeter. But as I mentioned in my lecture, if we put too much torque, we can overheat the bone because these implants are not heat conductors. So they do not absorb the heat. Whereas with titanium, the implant is a conductor, it can absorb the heat. We don't really end up overheating the bone. So with these implants, we have to use all the drills, go all the way to the last drill, use the profile drill, use the bone tap to make sure that we place it at about 35 Newton centimeter. But also we don't want to lose the primary stability. So in cases where the bone type is type 3 or 4, that's something we need to use our clinical judgments to see whether in that case go and use the profile drill in that situation. Is that going to cause loss of primary stability? In the one-piece design where the abutment is attached to the implant, which has great advantages. It's tissue level, there's no microgap, but if we lose the primary stability, then the implant can fail. So there is a very fine line between having a good primary stability, not putting too much torque to compromise the implant, and also getting a good sort of not overheating the bone. So it takes a lot of practice, and it doesn't take a lot of experience, a lot of, we have to be very careful and really feel the bone when we are placing these types of implants to make good judgments, basically. But if we really follow the direction and we have that perfect stability, then we should not run into problems.
Okay, doctor, there is a question. Can you briefly describe the process of ceramic implant restoration, how different it is from titanium implants?
So if it's very similar, if we use a one-piece implant, basically you can get the implants analog and impression copying from the company and just take the impression just like a normal titanium implant. But if you touch the one-piece implant, meaning you prep it, then you would have to just take an impression like you do for a natural tooth. For the two-piece implants, there is the straight and angulated abutments, but the angulated abutments are only, they're prefabricated. Also, the straight abutments are prefabricated, so you would have to purchase those from the company. There is no custom-made abutment at this point, so that's mainly the difference. You purchase the abutments, but if you, that's for the two-piece, and then for the one-piece, the abutment, it is attached to the implant, but if you prep the abutment, then you would just have to take a normal impression.
Again, doctor, you said angled abutment is available and in the preformed kit. But however, if I had to prep the abutment, that means I'll be generating heat even though I'm going to go with the water. That's a contraindication. How can I handle a situation like that?
So you mean if you want to prep the implant to correct the angle, how could
Correct.
you
Correct.
avoid that situation? Yeah.
Mhm.
So that's why I would definitely be careful in choosing to use the one piece. If you use the one piece, the angulation has to be right on. So because it's a straight abutment, we cannot prep it, we can't change the angulation. It's not recommended to do that. So one piece, it's better to use it in the posterior cases where we have also good amounts of bone and we can place it perfectly in the prosthetic position. For the cases where we need angulation, then we can do the two-piece and choose to buy the angulated prefabricated abutment from the companies.
Thank you. Is ceramic implants used for overdentures or hybrid dentures?
There are implants for overdentures. Yeah, we can use it for overdentures. Z system provides that sort of implant. It's a one piece for overdentures. Um, I believe also some other companies, maybe Celaroots probably uh, provides that, but I know that this system definitely does for overdentures.
Doctors, again, thank you very much for your birthday wishes. Yes, thanks a lot. I do appreciate that. Continuing with our questions, what company makes one-piece zirconia implants?
That many companies. I briefly showed there are uh, a lot of companies right now available actually. In Europe, there is uh, Z System from Switzerland is one of the oldest companies. They have both the one piece and the two piece. Strawman has one piece. Celaroots has one piece. Xeromex has the two piece ones. The Tab Dental, they have one piece. Z-Bone has one piece. SBS. So there are many, many companies actually that have the original one piece.
What are the chances of failure or breaking one piece?
There are cases, it's not very often, but that's why I emphasize the manufacturing procedure. So every implant company is different on the way they produce these implants. Uh, some of the injection molded implants may have porosities. If there is porosity, there could be possibility of fracture of these implants. But to be on the safe side, I recommend that if we choose to use this in patients that are Bruxelles, to always use a occlusal guard. Never leave them without occlusal guard if we choose to use a ceramic implant. And I would choose one of the companies that has the HIP processing, hot isostatic impaction, because this technique does not produce any porosities. So, for example, I think Strawman and Z System, those are one of the companies that use HIPing, and the chances are less. But the implants, as I said, the implants that we use today are very different than what was used back in 1970s. These implants don't fracture. There's a transformation toughening mechanism. The crack closes actually in presence of fracture. So for the most part, they are very tough. But as I said, if the patient is a Bruxer, I would always check for that and put the patient on occlusal guard.
Yeah, next question is an interesting one. Can ceramic implants be restored with screw retained restoration or it has to be cement retained crowns?
It can be restored by screw retain, but again, it's all prefab. So, for example, Ceramics and Nobel, also this system, they provide the screw retained abutment, and you can sort of attach the crown to the abutment and make the whole thing screw retained. But it's all prefab. It's not going to be the sort of a screw retained that's custom made. You send it to the lab and it comes back and you screw it. You have to make it that way, or just screw the abutment and then cement the crown on top of it.
Okay. Doctor, this is, of course, my question, especially in the aesthetic zone in the anteriors. If we lose the tissue, maybe because of periodontal disease or whatever it is, and especially the papillae, I know zirconia abutments would be handy. My biggest concern is how best can we restore it to get the good, pleasing aesthetic appearance.
So the question is, I'm sorry, could you repeat that again?
The question is, let's assume we lose the tissue, anterior zone, and
Uh-huh.
including the papillae and interdental
Okay.
papillae. And from aesthetic point of view, of course, you can use zirconia implants and abutments. How best can we restore the aesthetic appearance?
So if it that really depends on how much, if we have bone loss. If if we have bone loss, even if we use zirconia implants, then we are still going to have a papilla loss. So papilla loss is going to happen with whether or not we use zirconia or not, whenever we have the bone loss. What zirconia is, what it can provide is that in cases where we have the papilla loss and the bone loss, at least the implant color is white. So we don't get so much of the gray shimmering, but with the papilla loss, because of the bone loss, actually, most likely we are not going to get too much papilla back if there is bone loss. If there is no bone loss, we may, but it also depends on the bone level, interproximal bone level. If the interproximal bone level is high, we may get tissue to move coronally. But if we don't have the interproximal bone level, then um, we would have to fix that prosthetically with pink prosthesis.
Okay, this question is from Darius. In fact, he says he asked, his question is, what type of patient demographic do you notice being attracted to this implant type, zirconia implant type?
Yeah, it is mainly that. So there is a certain group of a holistic community that are very natural and just want nothing but organic, natural ways, and also no metals. They really emphasize that they do not want any metal in their body. Also, patients that are really sick, they have been through cancer therapies, chemotherapy, their immune system also is not too well. This is a good option because it's this material is not, it's very inert. It's biocompatible. I mean, titanium is also very biocompatible, but zirconia, like I said, it doesn't really lead to foreign body reaction because the whole material is oxidized. So for patients that are, sicker patients, they have had multiple diseases, I think this is a healthier option. And then also for patients that are really worried about aesthetics, I would definitely go with this option. And patients with history of periodontitis, I see a lot less plaque forming on these implants. I'm not saying that they will not have peri-implantitis. I mean, they always have to get their regular cleanings, but these implants, studies have shown less plaque, less bone loss. So I think it is a good option also for patients that have had history of periodontitis. And then also the ones that are concerned about, like I said, metal allergicity or metal being in their body. So it really provides an option for a large group of people out there that are looking for implants, but this is sort of their requirement.
Okay, is there much of a cost difference to the patient, titanium versus zirconia?
Yes, it is more expensive with zirconia because the material, the implant is actually more expensive than titanium. Uh, there are also cheaper zirconia implants depending on the way they are manufactured. Some of the companies that use injection molding, they may have the implant cheaper, but the ones that have more of a modern technique, the implant is also more expensive. So the treatment would be more costly for the patient.
When you say it's more expensive, how much more expensive is it compared to
It's
titanium?
twice or 2 to 3 times more. Yeah.
Okay, from your experience, if you can list it, are zirconia implants better than titanium?
Uh, it's hard to answer that question because I use also titanium implants, but yes, I think in my opinion, it's not perfect yet because prosthetically we are still not there with zirconia, but I think in with certain situations, yes, I think zirconia is better. Definitely, I do see it clinically in terms of the soft tissue attachment. I get excellent results with zirconia. So and when we get a good soft tissue attachment, we get less plaque formation. That means that long term, we may have less chances of peri-implantitis and complications down the road. And for the clinical publication I went over that we published, those patients were, we evaluated those cases. It was 6 years maximum now. It's about 8 to 9 years. But looking at those cases, over a long time, there's really not much bone loss with zirconia. Part of the reason, I think it's because of the tissue level nature of the implant, and also the other reasons such as less plaque, less and less plaque leads to less bone loss. So I like these implants a lot. I think that it could be in the future, maybe not too soon, but in the future, it could possibly be an alternative, better material than titanium.
All right. Can you connect a zirconia implant with a titanium one? For example, for a 3-unit fixed bridge.
No, I don't recommend that. It's different forces, different material, uh, different mechanical properties. So I wouldn't recommend doing that.
Okay. Dr. Kotal, you had something to comment. Would you come down and talk on that? Dr.
Yeah,
Kotal?
yes, it's more of a question actually for Dr. Munzavi. I'll just read out my question, Dr. Monzavi, and this is something that I would like to know. I think the audience would also love to know this. So if you consider the fact that the titanium is the go-to material for all types of hard tissue replacement, that you take the hip and the knee joint or whatever it is, right? I mean, if you're using in craniotomy or any of that, where do you think the material science itself has evolved to replace titanium? Because the next step to all this seems to be 3D printing, which rather than actually increasing the cost to the patient, actually brings the cost down. So where do you see the material science of this going in terms of actually scientific, acceptance in the scientific community, and then, of course, the patients?
I think the material is actually evolving very fast, and it, the mechanical properties, I think it's going to be improved even more because the material, now there is more research on the material to make the mechanical properties even better. And titanium, yes, it has been always the go-to also for prosthetics, orthopedics. The main reason for that has always been because of the better mechanical properties of titanium. So the better fatigue resistance, and it doesn't fracture, whereas zirconia or ceramics are still, it's a ceramic material. So we have to consider that. But since the ceramic material is evolving so much and it has changed so much from what it was before, and as we are speaking, for example, now they have added more alumina to it to improve the mechanical properties even more. And now there is talk of having addition of some other elements, small amounts. So I think that at some point, the mechanical properties will be very close to titanium. That 3D printing definitely would take place in terms of dental implants, I think for sure.
Thank you, Doctor. The other question is, you showed a slide, I think it was tooth number 31, the implant titanium implant failed. You said you replaced it with zirconia implant. The question is, why did it fail? What is that different you did to restore that area?
So the implants had a condensing osteitis. It failed after about 5 years in function. There was not much bone loss around it, but it was just loose when I went to check it. There was inflammation. Also, patient did not really come back for follow-ups until she felt that the implant is loose. So could be many reasons. I'm not sure if it was clearly peri-implantitis. Could be also foreign body reaction or just other form of foreign body reaction, because there was not a lot of bone loss crest study around the implant. What I did different was, well, the patient was also very interested to have another material, because she thought maybe her body is not reacting to the implant because the there was no peri-implant infection really. It was just loosening of the material. She wanted to have a different option, and so I thought about placing the one-piece zirconia implant, which is very advantageous in situations to prevent later peri-implantitis, I think, because it's a one-piece tissue level, so there is no micro gap to pump the bacteria in and out. That's one reason. And then the tissue level nature brings the margin at the tissue and above. So this way we won't get bone loss with the implant. It's a great option. It's different material, more inert. So that's why I went with this option. And I really think in cases where we can do the one-piece implants, I think they are the best option. But you know, we are limited prosthetically. Angulation has to be perfect. Also, the most difficult part is the post-op because these implants are exposed. So we have to give the patient a protective stent to wear. Many times they don't wear it, and then they come back with the implant in 3 months, and that implant can be loose. So patient has to be compliant with wearing the protective stent during they can be these implants. That's very critical. So patient selection for these cases is very important.
Doctor, would you repeat that last sentence? Looks like I lost you. There was the drop in the internet. Would you repeat that last portion, please? What you just now mentioned?
Oh, I basically said that, you know, I really like the one-piece implants because there is no micro gap and it's tissue level, so the margin is above the bone. We will not expect to see a lot of bone loss. It's cleansable, but the most important thing about the one-piece is patients have to comply with wearing a protective stent during the healing time. Any trauma during the healing time can cause the implant to fail because any movement on the implant can be an issue, can traumatize it. So we have to select the patients and select the compliant patients that are willing to wear a stent over the implants for about 3 to 4 months before we restore them.
Thank you. Doctors, again, if you have questions, please post it. Now it's already 10 till 12. We will start winding up. And I guess I got a question for you again. Uh, Given a chance, you prefer titanium implants because that's your specialty, which I could fully understand. I'm sorry, ceramic implant. Under what condition would you pick titanium versus zirconia implant?
Yeah, full map cases, I would choose a titanium, like, you know, cases where patients are severe bruxers, teeth are worn down, and the patient needs full mouth rehabilitation, then I would pick titanium in those cases just to be on the safe side. Because like I said, the material, it doesn't fracture easily, but it's still, it is a ceramic, it is still evolving. So in severe bruxers that, you know, and they're not compliant with wearing a night guard, you know, many times they say they wear it, but they don't like to wear it, then I would just consider to go with a titanium implant.
Again, doctors, I think this will be the last question. If you have anything, please post it as soon as possible. And doctor, I just want to kind of make myself sure. Do we have angled abutment to correct misalignment? You said only thing is preformed. Am I
Yeah,
understanding correct?
yes, yes. The only thing is prefab to 15 degrees.
If that is the case, that's going to put me in a kind of binded position. I cannot
Yeah.
grind. I got to be cautious. What would you do? How would you handle a situation like that?
Then if, like I said, in cases where we need angulation, and I would just go with titanium because we just don't have enough options with zirconia.
Okay. Thank you, doctor. Thank you very much. It was a great presentation. Thanks,
Thank you.
Darius.
Thank
Thank
you for
you,
the
Dr.
invitation.
Kamal. With
Thank
that,
thank you.
we'll start wrapping it up, and you will get 2 units, and it will be in your email by tomorrow evening for sure. Thank you. Have a great rest of the week. We'll see you during next webinar. Thank you.
Thank you, Dr. Prasad.
Thank you. Thank you.